So a warm welcome to everybody for day 2 of our 2021 ISNTD D3 Drug Discovery, Development and Diagnostics. We had a wonderful day yesterday. We had panels around reimagining finance, the financial incentives for both therapeutics and diagnostics. We looked at access in terms of redefining access and the impact of access all the way along the R&D value chain, from early discovery, TPPs, all the way through to product. And then we also had a couple of disease-focused sessions yesterday looking at snakebite and antivenoming from an access perspective, a partnership perspective, and then leishmaniasis in terms of both visceral and cutaneous, looking at some of the clinical development steps that are in place, some of the access programs that are developing around that, and some of the issues that needed to be unpacked in terms of future direction. We also had a very interesting session from the US FDA looking at repurposing as a strategy within early discovery. One of the kind of key things that came out of yesterday, and it's always really been the case, has been really the massive gap when it comes to diagnostics for NTDs. And that's been there since the beginning. This is our 7th annual D3, where we've always had a dedicated second day looking at diagnostics and the gaps there, whether it's at field, whether it's at the clinical, at the lab level, all the way through the last 7 years, we've always seen this kind of gap. A lot of things have happened in the last year, and principally I'm talking really about the COVIDization of all of the work that we're all involved in. And one of the most important things that COVID has, the upside, if you want to call it that, for want of a better expression, has been this really sharp refocusing on the critical importance that early rapid diagnostics can have in terms of clinical management of a disease or containing outbreaks. It's always been the case in the NTD world, but I think now in the public domain, COVID has really sharpened that focus into the importance of diagnostics per se. So we're very, very happy to and delighted to welcome everybody to this day. It's going to be diagnostics dedicated. We've got a lot going on, and you can see that we've got we're going to start with a very interesting talk. 3 years ago, the World Health Organization put out something called the Essential Diagnostics List, a seminal bit of work. This is the 3rd iteration of that. I believe it came out on the 29th of January this year. And really, we're delighted and honored to welcome to the floor to open the day Dr. Francis Mussi, the Secretary at the SAGE, the head of the SAGE IVD and Essential Diagnostic List at the World Health Organization, talking really about the launch of the 3rd Essential Diagnostics List and how we can all get involved with that as a diagnostics NTD community. We're going to move from that to Dr. Didzom Komi de Souza, Senior Scientific Officer at the NTD program, one of the most successful PDPs in this sector. Yesterday, we were blessed with having the DNDi talk about their PDP approaches for therapeutics. Well, I think hand in glove, really, with that are the huge successes that FIND have enjoyed, the Foundation for Innovative New Diagnostics. And what's really interesting in Didzom talk, we're going to be talking about really access issues. And here, in that particular talk, be a talk on visceral leishmaniasis and impact in terms of the getting towards elimination targets in Kenya. And then from there, we're going to move out into a more of a disease focus for schistosomiasis. We're looking at how modeling can inform this kind of approach in diagnostics, and then looking at different diagnostic markers in terms of monitoring praziquantel treatment at trial level. And so that's the kind of morning in a nutshell. So I think I'd like to introduce to the floor Dr. Francis Mussi, the head at SAGE IVD and the Essential Diagnostic List at the World Health Organization. So Francis, if I could ask you to just bring yourself back onto the screen. Good morning to you. A round of applause, and I think I'll just pass over the floor to yourself.
Thank you very much. So it's It's a real pleasure for me to be here today. Can you confirm that you can see my slides?
Yeah, we've got it perfectly. We can hear you, Thank you.
Thank you very much. So today I will describe a little bit the EDL, and I will give a little bit of a highlight of the what we have in the third edition of the EDL. So my presentation will includes the objectives of the EDL. So why did we decide to create the EDL? Then I will describe briefly the benefits for countries for having an EDL. I will also mention the scope of the EDL. And very importantly, I will talk about the process that we use to develop the EDL. And I will finish by giving some highlights of the EDL3. So if I continue, what are the objectives of the EDL? The EDL is really to help countries develop their own in vitro diagnostic policies. It's really, and this is ultimately to improve treatment of patients by using the right diagnostics. So the EDL lists a set of priority in vitro diagnostic categories for use at various levels of the healthcare system. The EDL provides evidence-based guidance to member states for the development of local and national essential in vitro diagnostic tests. The EDL also informed the United Nations agencies and NGOs who support the selection, procurement, supply, donation, or provision of in vitro diagnostics. And also it provides guidance to the diagnostic industry on what are the diagnostics priorities that are needed to address global health issues. So what are the benefits of an EDL? Well, the EDL support countries to prioritize their own testing and infrastructure needs. It also helps support outbreak preparedness by making a test available. It also facilitates the development of high priority new IVDs by industry and funders by highlighting the needs. And also it's help ensure safe and rational use of medicines in the list of essential medicines by making tests available. And finally, the EDL can also help increase affordability by facilitating bulk and advanced purchasing of IVDs. So let's talk now about the scope of the EDL. First, I think I want to make it clear that the EDL does not include brand names or specific products, but it includes categories of tests. I think this is important to understand that. For example, we will talk about malaria RDTs, malaria rapid diagnostic test, but we will not give specific brands. Also, the EDL includes categories of tests for both infectious diseases and non-communicable diseases. It also includes general laboratory tests, for example, like HIV, TB, malaria. And the process that we use to develop the EDL is a little bit similar to the process used to develop the essential medicines list, but it's adapted for in vitro diagnostics. The process for adding or removing tests from the EDL is overseen by a technical advisory committee that we call the SAGE IVD. And the SAGE IVD has already met 3 times to make recommendations on the 3 editions of the EDL. And I will give more details about this SAGE IVD later in my presentation. So this this slide shows the inclusion criteria for the EDL. Well, we have a test that are used at the primary care levels. And this is for patients are at entry-level care facilities. We also have tests that are used at higher level facilities. Here, this is for laboratory-based technologies. This is for facilities with laboratory-based technologies and methods. It's important for tests that are added to the test that they have high public health relevance. For example, high burden of disease, and they also need to be affordable and appropriate. And very importantly, when we add the test to the EDL, this needs to be supported by strong evidence. So this is evidence-based. And this is supported, for example, by WHO guidelines, by guidance documents, by systematic reviews, and so on. And another very important concept here is that the entire process for adding tests to the EDL needs to be free of conflict of interest. And so we had categories of tests, but obviously for these categories of tests, we need to have commercially available tests with regulatory approval. And this test needs to be available for procurement worldwide. So the priorities and the directions are set by the CJVD every year. So this is the way the EDL3 is organized. And you will see a little change compared to the first and second editions. Here now we have three sections. The first sections are for categories of tests in a community and healthcare settings without laboratories. And for this section 1, we have two subsections. The first one are general tests that are arranged by discipline, for example, like hematology. And we have another subsection, which is for disease-specific tests arranged by diseases, like HIV, TB, malaria. Then we have section 2, which is for healthcare facilities with clinical laboratories. Here we also have a subsection on general tests, also a subsection on disease-specific tests, but we have a third subsection on a blood screening test. And this year, we added a new sections, which is called the do not do recommendation sections. And this is really where we make strong suggestions that some specific tests should not be used. For example, for TB, some TB RDTs. Okay. Next slide. So here is an example of an EDL entry. If I start by on the left, you can see that we have the HIV. So this is for the disease column. Then the next column is for the diagnostic test. Here we indicate the analytes being measured. The next column is for the text purpose. Here we provide a brief outline of the common reason for performing the test. The next column is an assay format. Here we include the recommended methods for performing the test. So we do not include brand names. Then the next column is about specimen types. Here we include the typical specimens used for this test. And the next column is about the link to pre-qualified or endorsed products when they are available. And the final column on the right is the links to guidelines and guidance documents. So, as I said, the development of the EDL is overseen by a technical advisory committee. So it's called the Strategic Advisory Group of Experts, or CJVD. It serves as a principal advisory group to the WHO Director General on all aspects of IVDs, including the EDL. This committee has an adequate representation of expertise. It has a geographical representation, gender balance, and we also have a very strong management of conflict of interest. And this committee, the members of the committee serves for 2 years, and this can be renewed once. And I want to mention here that we are in the process of renewing this committee. So if some of you are interested, you may apply. It's a highly competitive process. The information for submitting your application is posted on the WHO website, and I will provide the link at the end of my presentation. So here's the process to update the EDLs. So first, we have 5 different types of submissions. We have addition of a test category. We have edit to an existing EDL entry. We have removal of a test category. We also have do not do recommendations. And we have submission of additional evidence to reverse a conditional listing. A conditional listing is when, for example, a test has been recommended for addition to the EDL, but there was not enough evidence available, for example, at the time for full addition to the list. So we requested additional information. So the process is that we request we first issue a call for submission. So we receive the pre-applications. Pre-applications are reviewed internally to make sure that for example, they don't contradict what we have in our guidelines. Then, if it is okay, we ask the applicants to submit a full submission. The full submission are then evaluated by at least 2 members of our SAGE IVD committee. The submission and the outcome of the reviews are posted on the WHO website for public comments for 1 month. Then the reviews as well as the comments resulting from the public consultations are discussed during a face-to-face or virtual meeting of the SAGE IVD. And the SAGE IVD will make recommendations on the inclusion or removal of tests in the EDL, as well as the precise wording that is used when the tests are included in the EDL. And then these recommendations are presented to the Director General. So I will not go into the detail of this slide because there's a lot of information here, but basically this is the type of information we request in our submission for addition of tests. So we request applicant informations. We also request information on the disease and conditions addressed, including the public health impact and the use of the test. We also request a description of the categories of tests, the intended use, the detection targets, the intended users, and so on. We also, very importantly, request information on the evidence available. For example, on the diagnostics accuracy, the clinical utility, and so on. And also we ask for information on existing guidelines and also technology landscape to make sure that there are commercially available tests that fit into this category. And we also request information on the societal impact, as well as a little bit on the budget and resources. So then, as I said, the submission to the EDL are discussed during a face-to-face or a virtual meeting of our advisory committee. These discussions and recommendations, as well as the new EDL, are published in a document shown here in blue, which is a selection and use of essential in vitro diagnostics. So this document also includes the EDL. So for the EDL3, here are the updates. So we received 28 applications. We also received 26 changes that were suggested. We received 5 sets of additional data to lift conditional listings. So now the EDL3 includes 175 test categories, as well as 2 do not do recommendations. Some highlights of the EDLs are shown below. So we included tests for COVID-19, both the nucleic acid test and also antigen test. We also added a section on endocrine disorders. We added a point-of-care sickle test. We also added additional cancer tests, additional fungal disease tests, such as aspergillosis and pneumocystis pneumonia. We also added vaccine-preventable diseases, and we made changes to general tests. Regarding NTDs, I think now we have about 8 categories of tests for NTDs, and I will certainly encourage you to submit additional categories of tests for NTDs. I think we need to have additional ones. So I think I will go to my last slide now. So this slide provides you the link for the TRS document, so the document I showed before, where you can find the EDL. On that web page, you can also find infographics, brochure, various documents regarding the in vitro, regarding the WHO model list of in vitro diagnostics. You will also find information on the SAGE-IVD committee and how to apply if you are interested in being considered to be a member of this committee. And there is also the email address of the EDL secretariats. So I think I will stop here, and I will be happy to answer questions. Thank you very much.
Thank you very much indeed, Francis, for that. Quite a robust look at the EDL and its workings and how people can approach that. As you said, you're very kindly opened up for some questions. I know you have to dash after this, so we've got you for about, I think, 5 to 10 minutes maximum in terms of questions. There are some questions coming through, and I'll come to those in a second. One question that I wanted to ask you is, obviously this list is a list. It has to be adopted by countries, and one of the key points there is that it enters into this basic national EDL. Our national EDL guidelines are drawn up per country. I know you've done that with India, Nigeria, Bangladesh, and Pakistan, or currently engaging with those countries at the moment. I just wanted to open up a little bit, because a parallel development is also the WHO's NTD roadmap guidelines, and part of the shifts contained in that are that they're encouraging people to move from an external-led approach to a more country ownership model. I just wanted to ask you, how is that shift affecting the uptake of the EDL?
So I would be very happy to answer that. Yes, you are absolutely correct. So the EDL needs to be adopted and adapted by countries, and so countries need to develop their own national EDL, using our model list of in vitro diagnostics. We are actually in the process of developing a guidance document to countries develop their own national EDLs. And actually, my next meeting is on this topic.
Oh, fantastic!
But so we hope to be able to publish this guidance document in a few weeks. But we are also planning to have a direct involvement with countries to help them, develop this EDL. For example, I was talking to a colleague from Afro, from the regional office in Africa, and he mentioned that, for example, 15 countries in Africa are interested in their national EDL. So we may need to organize workshops, webinars to help countries develop that.
That's fantastic. And I suppose part of that engagement with those countries is better coordination and access to the EDL. And on that basis, I know that you've put, there's an electronic version that's available I believe it's a beta version. Is that correct?
Yes. So we created an electronic version of the EDL, so it's a beta version. So you are correct. So we still have a few bugs to work out, but I invite participants in this conference to test the beta version of the EDL and send us your feedback.
Okay, brilliant. In terms of feedback, Francis, thank you for that. And I'm sure a lot of people will engage with that and help to shape that somewhat as well. I think it's fantastic to have it in an electronic format. It does encourage use of it and kind of engagement with it. We've got some questions coming through. If you don't mind, I'm going to ask one from Dr. Aubrey Cunnington, who's going to be speaking later in terms of digital diagnostics for Africa. But Aubrey is asking from Imperial College London, do you have any data on the availability of EDL diagnostics within different countries? What proportion of the population in each country or continent has access to essential diagnostics that they need? Do you have that type of data?
I'm not sure I understood the question correctly. Did you ask if we have data on the
availability of the EDL diagnostics on the list within different countries?
No, we don't have this information yet. This is something that we want to get, but we don't have it yet.
And I hope, well, through the continued engagement of this audience and post this event, that those kind of data sets will start to fill out. I hope that answers your question, Aubrey. Professor Lisette van Lieshout from Leiden University has said, you mentioned no specific products or brands. But what if only one product or brand is available, like the POC CCA for Schistosoma mansoni?
Yeah, it's always a difficult question for us. When it happens, we will still list a category of tests. Even if there's only one test, but this is to also not close the door for other tests that could, fit into this category at a later stage.
Yeah, and I suppose it also speaks to the innovators, because you can instantly see that there's a gap, and we need to kind of move into that gap somewhat. So that might encourage that kind of flow. If you don't mind, there's another question from Mitasha Bharadwaj, who's going to be speaking later from the University of Delft in the Netherlands. What is the difference between EDL and TPP?
Oh,
yeah.
So an EDL is a list of categories of tests. A TPP is a target product profile. A target product profile is a document that provides characteristics of tests that needs to be developed. So it's really quite different, because a TPP is something that is really upstream. So it facilitates the development of tests. In the EDLs, we only put categories of tests that are commercially available.
Okay.
So the TPP is really to facilitate the development of tests. So for R&D, really.
Okay, great. So that's a great question and answer there. Thank you. I'm having some questions coming through from Roger Natolo Mabiala. What do you mean by the good use of diagnostics? Could you explain that, open that? What do you mean by the good use? And also a second question by Roger. He wants to understand, what do you mean by do not do recommendations?
Yeah.
The good use and then the do not do.
Well, the good use of tests. Well, I don't think I use that terms, but it's appropriate use of tests. For example, there could be an overuse of tests. In some cases, we don't really need to have the test. Maybe the clinical judgment can be good enough. Also, the appropriate use of tests. For example, if we are talking about antimicrobial resistance, it's important to use diagnostic tests in order to not prescribe antibiotics when it is not needed, for example. So this is an example. Now the do not do recommendations. Here, for example, for tuberculosis, in their guidelines, they did mention that some categories of TB serological RDTs should not be used because these tests don't have any value at that time because the tests are not good. Perhaps in the future this might be changed, but right now this is not useful. So this is why there are some categories of tests that are commercially available, but we really do not want to see them used because they're not good.
I think that's a very good answer. Thank you very much for explaining that. I'm sure Roger's happy with that. We're getting a lot of spread in different countries. So we've got people joining us already from India, South Africa, the UK, Glasgow, in Scotland, also across Africa. We've got people joining from Tunisia. And we've got a question coming through here from Sri Lanka, from a researcher there called Maluka. Will your guidance document for countries to adopt the EDL mainly focus on only diseases that are prevalent for that specific country, or how broad will it be?
Well, the guidance document is going to be broad. It describes the process that we suggest countries to use to develop their own national EDL. So each country will need to decide what are their priorities. So we ask countries to adopt and adapt the EDL.
I suppose part of that adoption and adaptation process is listening to the people in terms of their actual access needs,
exactly,
and letting those voices inform not the TPP but the adoption of into the national EDL program. In your work with Nigeria, India, Bangladesh, Pakistan, in terms of making their national EDLs, what kind of mechanisms were they employing to let's say translate the voice in terms of the access needs and push those into their national EDL? Did you come across any specific kind of mechanisms that they were using, any best practices, anything you could shed some insight into?
Yeah, well, I cannot really comment on that from these countries, but in our guidance we will suggest some mechanisms for that. Mm-hmm. So we are kind of reviewing that now, but this will be included in our guidance documents. So, but it's very important that the people developing the national EDL get the feedback from people using the test. So it's very important.
I think that's a very good place to kind of, a lot of people saying thank you, including all the people. Thank you, Francis, from Natasha. That sounds good. Thank you from Roger. Thank you, Francis, from Miluka. All the questions that you've answered very kindly. So the one thing that I'm getting from this is that there's such a wide country spread. There's so much desire to engage with you guys that I do think, especially in this diagnostics field, that I think the inputs into the fourth, this is the third EDL, but the inputs into the fourth EDL, how can we approach you? Is there a pathway to get to you? What's the kind of best way to help shape that fourth iteration?
Yeah. So for the fourth iteration, we will be issuing a call for submissions. So it will be issued probably in a few months, because we will just publish the third edition. So I think this call for submission will be published on the WHO website, but we will also be advertised through the various relevant networks.
Brilliant.
And then please submit an application. Submitting an application is a fair amount of work.
Yeah.
Be prepared, because we ask for a lot of data information. So
perhaps in the fifth iteration we can streamline that submission process. But I do think there's a lot of people who are going to be engaging with you moving forward. This is a critical piece of work, seminal piece of work that the WHO have been involved with, and I think a lot of people are saying thank you and are very happy to be engaged with you on that. I think we've come to the end of the time allocated for the questions, Francis, and I'm very wary of the fact that you have to go on to the other meeting. I'd just like to say thank you very, very much. Time is never enough. Once you start engaging questions, you start seeing lots of stuff coming through in the chat boxes. So thank you to yourself very much for opening the day and setting the kind of scene there. I think it's a nice segue in terms of access and barriers, which the next speaker from FIND will be addressing. But from all of us here, Francis, I'd just like to say thank you very, very much indeed. You heard it all here. There'll be submissions. This is the third EDL, but obviously for the fourth one, there'll be submissions being open in a few months from now. And in any case, you can all engage with the electronic version as well as contact with the links that Francis very kindly put up. So I'd just like to say thank you very much, Francis, from all of us at the ISNTD and on behalf of the audience as well.
Okay, thank you very much for inviting me, and I'm looking forward to getting your input on the EDL.
Thank you very, very much indeed. Take care. Have a great day. Thank you.
Okay.
Thanks a lot. Bye-bye. Okay, so that was a wonderful opening session in terms of the EDL, setting the kind of scene, really pushing countries to adopt their own versions. As you heard there, Nigeria, India, Pakistan, Bangladesh have all jumped to this and are really engaging on that. And as you heard, some very interesting landscapes opening up across Africa in terms of African states engaging on this basis. So hopefully the gap in terms of diagnostics gap for NTDs will be addressed in the coming months. And this particular initiative by the WHO should be something that we are all engaging with, and we're very honored to have Francis open that. That brings me to the second speaker for this morning session. As you heard there from Francis, one of the critical points of adoption of this EDL is really going to come down to translating the access needs, recognizing the access barriers per country on a grassroots level, and really translating that into a national EDL. So what we wanted to do was to invite basically the world's leading PDP, the most successful PDP in diagnostics from day one, and that's the Foundation for Innovative New Diagnostics, FIND. We have the pleasure of welcoming Dr. Didzom Komi de Souza, the Senior Scientific Officer of the NTD program. And we wanted Dr. de Souza to speak really around the access issues for visceral leishmaniasis diagnostics and the impact towards attaining the elimination target in a site-specific area, Kenya. So I think a round of applause for Didzom. Yeah, looking great there. And I think I'll just hand over the floor to you, and I'll just back out.
Yes, okay. So thank you very much for the opportunity to be here. It's good to talk on the work we are doing at FIND. This presentation mainly is about how local information can be used to strengthen the decision on where to place diagnostics in order to make an impact. And we are happy to see that the direct agglutination test is on the current EDA. So that's good news. Next slide, please. Okay, so just very quickly on visceral leishmaniasis. It's one of 3 leishmaniasis, and it's globally it's common in Latin America, mostly Eastern Africa, the sub-Indian continent, and part of Asia. But with the success of the elimination in the Indian continent, there's more and more increase on being given to Eastern Africa. So in Eastern Africa, it's mainly caused by Leishmania donovani. There are many challenges to the control of visceral leishmaniasis in Eastern Africa. But one of the main things is the epidemiology, which is not fully understood. There is transmission by vectors. There can be human-to-human transmission, and there are also reservoirs that are there in the communities. And yearly, there are many thousands of cases reported. Another challenge is the performance of the current tools that we have, the RDTs. Performance is not as good as in the endemic areas, which leads us to having a more complex diagnostic algorithm in the region. And basically, it's one of the diseases that's been targeted in the new WHO roadmap for elimination as a public health disease. So in Kenya, Kenya is one of the top 10 high burden countries in the world, and it reports roughly 1,000 to 1,500 cases every year, although this is believed to be underreported. And the disease is endemic in 8 counties. It used to be 6 counties: Turkana, Marsabit, Isiolo, Wajir, West Pokot, and Baringo. Last year, there was an outbreak in Kittu and Garissa, which have been added. And this year, we're hearing of cases being reported in another county. So the epidemic situation keeps varying from year to year. But the main challenges basically are inadequate access to diagnostics and drugs. There are recurrent outbreaks. The cost to patients and to the health system is huge in taking care of the patients, providing their food, their admissions, the labor. And there's also low disease knowledge by health workers. And this is also made worse by the fact that there's high turnover, so we have to keep training health workers constantly. And there's also low disease knowledge by the local population in terms of seeking healthcare early. And one of the other challenges is the poor use of data to strengthen surveillance. So there have been many reports of VL outbreaks in Kenya, and usually they are sensational in the news, leading WHO and other partners to try and address the situation as best as possible. So our work has found mainly is to improve access to diagnostics and eventually treatments. And we use a phased approach. First, there is a need assessment, mapping and identifying the health facilities in the counties, which is followed by the strengthening the laboratories, improving the infrastructure, supporting with equipment where needed. And then there's a training of personnel, both laboratory and case management. And we supplement these activities by community awareness, behavior change communication. And finally, we do monitoring and evaluation. And so basically, we aim to have a network of health facilities that provide diagnosis and treatment in endemic areas, thereby improving the patient's management and welfare. Also, one of the aim is that at the end, we can have a VL access model that can be replicated to other countries within the region. So our activity started in 2016 in Turkana County. And in 2017, we added one more county, Wajir. In 2018, 2 counties were added. Last year, 4 counties were added. So we're currently in all endemic areas, all endemic counties in the county. So at the moment, there's a network of more than 80 health facilities that provide diagnostics to the local communities. At the start of the project, there were 22 facilities that were providing diagnostics, and this was increased by more than 60 facilities through our activities at FIND. So this is quite significant in terms of making sure access is provided to the population and leaving no one behind. So what I'm going to do next is just take the example of one county, the Marsabit County, and how analyzing the local data can help in deciding the placement of diagnostics and the impacts on other indicators. Marsabit County had 3 epidemics in 2014, 2017, and 2019. And our activities in Marsabit started in 2018. And basically what you see here is the distribution of cases in the 2 epidemics in 2017 and 2019. So basically by mapping the communities and mapping the health facilities, we are able to trace which communities report to which facilities. and how that can be used to improve the decision on placing diagnostics. So what you see here is a network diagram, and on the left you see the situation before 2018. And on the right you see the situation after we added 2 new health facilities. And basically, this shows you that by adding these 2 facilities, we reduce the distance that patient had to travel by from 26 kilometers to 9 kilometers. And for VL cases, that distance reduced from 28 kilometers to 10 kilometers. So this is significant, and this just by adding 2 facilities. But there are other considerations in adding or removing facilities. So for instance, this facility here, Ubisa, which is here, by adding 2 facilities, its relative impact is reduced. So then we also looked at how best can diagnostics be placed to improve access in terms of travel distance. And these 2 plots show you the distance that patients had to travel to access diagnostics. And basically in this plot, here you see the facilities. The dots represent the communities that access diagnostics in these facilities. And for this first community, for instance, they don't have to travel far to get access to diagnostics. However, making the decision to keep or to remove a facility has to be made with very good care. So if you look in the next plot, you then see that by removing this facility, patients have to travel almost 50 more kilometers to get to the next facility before they could access diagnostics and treatment. And you can see the same for when all the other facilities are removed. So this kind of gives us a sense of which facilities are important in the counties, which facilities need to be strengthened more, and how to address facilities that have relatively less impact. We've also seen by analyzing the data from the various epidemics that there's a shift in the demographics in the age structure. And so from we went back to look at 2014 epidemic compared to 2017 and 2019. And basically we see that in 2014, the population, the cases 0 to 10 years were 35%, but this is gradually increasing. In 2017, it was 47%. In 2019, it's 59%. And we think this is linked to all the supplementary activities, the community education, the behavior change, advocacy that has gone into the work to inform communities about the access to diagnostics. And so we also think the older population gradually gets to know more about the disease, and so learn to better protect themselves. So cases are more and more reported in the lower population. But we also see an increase in cases in the female population in these age groups. There are also the impacts on other indicators. So for instance, by looking at the 2 different epidemics, you see that between 2017 and 2019, there is a lot more cases that have been reported in this county. And again, we link this to all the community education, the behavior change, leading patients to, and also not just the patient, but also the health facility to know more about the disease, and therefore they are testing more people and therefore diagnosing more people. But despite the increase in the number of cases that is observed, you can clearly see that the mean patient delay, that's the time from onset of symptom to treatment, is gradually reducing. And in 2017, it was 47.9 days. In 2019, it is 21 days. So this is a positive impact in terms of patients seeking early diagnosis and therefore getting early treatment. So beyond diagnosis, there are other benefits to the health system. By contributing to the control of VL in Kenya. Currently, the current death rate is at 1.8%. And according to the new WHO NTD roadmap, this needs to be brought to less than 1% for the country to be considered as having eliminated VL as a disease of public health. So if we keep working at the rate we're going at, we believe this is achievable in the next couple of years, but it will require a lot more effort from all the partners. This presentation also shows that optimal placement of diagnosis reduces the distance to patients and therefore the costs to the patient. They don't have to travel farther. They can easily access diagnostics in the closest facilities. But there's the need for local data to strengthen the interventions, and analyzing individual county information could help in targeting activities and resources where they are most needed. There are also impacts at different levels. There's impact to the health system. The diagnostic capacities of the health centers are being strengthened, and the access to treatment in the endemic communities is being reinforced. The health of the local population is being improved, and by bringing diagnosis closer and improving behavior change communication, we are reducing the costs associated to illness, and also making an impact to VL control. Early diagnosis leads to early treatment, which leads to reduced risk of transmission, and thereby we are also improving the coordination with the partners, the other partners in the country, which is very critical. There are so many challenges, and there's the need for a horizontal, vertical, to look at changing from a vertical to a horizontal approach to targeting activities. But this is my final slide. There are also some challenges to be considered. One of the challenges is poor adherence to VL diagnostics algorithm. And because of all the education, there are more and more people being tested, and the diagnostic algorithm is not being strictly followed. So this is resulting in a lot more patients being tested negative. And the tests are currently expensive with global supply shortfalls. So we need to strengthen the diagnostic algorithm, making sure that clinical suspicion is strong, making sure that other diseases in the endemic areas that may mimic VL are ruled out first before going on to diagnose patients. And we also see late health-seeking behavior in the population, which sometimes results in delayed treatment and therefore fatality. And so this needs to be improved. And finally, there's the need for financial sustainability to support the VL activities. The local counties, they try their best to support the costs to the patients, the feeding, the labor costs, but there's need for support from both the national government and the international funding donors to be able to support the activities. So that's about my presentation. I'd like to thank my colleagues who've been involved in this work and the various partners. There's WHO, the Kenyan MOH, the county MOHs, KEMRI, DNDI. They've been very supportive, Probitas Foundation, ASCEND, and WHO, who have all been very supportive in the activities in Kenya. So thank you very much.
Thank you very much indeed, Didzom, for a fantastic presentation. We often think about access in very abstract terms, and here you've really shown how in-depth country analysis can really yield some interesting touch points in terms of using access and shaping it in terms of actual next steps, especially some of these touch points around the late health-seeking behavior, the impacts in terms of the healthcare system itself, and kind of next steps. Very interesting to see the knowledge gap that you are addressing at some point there at the HCP level. I'm sure we'll come back to all of this in the Q&A, but I'd just like to say thank you very, very much for a fantastic presentation. We really wanted to kind of open the day with the WHO in a broad sense, and then look at access. And we felt this was a perfect presentation, and it really shows the kind of in-depth work that FIND are involved in. Fantastic, perhaps even a blueprint there on how countries can engage in terms of their access requirements when they're forming their national EDL. So much that's going to come out of that work. So thank you very, very much for that. We're going to have you rejoin the panel at the end of the next two speakers for a bit of a Q&A, and I'm asking all the audience to put some questions in, which they are. And on the audience, I'd just like to say a big, we've been joined by quite a few other people in the interim, especially for that talk. So Dr. Seema Rafati, all the way from Tehran in Iran, Annabelle Monet from Sanofi Pasteur in Lyon, Dr. Maria João Govia from the National Institute of Health in Portugal. We've got Helena Uliata. Dr. Uliata is from the Ministry of Health in Indonesia. So there are a lot of people tuning in, a lot of interesting outputs from that work. And I'm sure a lot of Delna Gandhi, the ex-DFID person, has come up with a wonderful presentation. Great to see the impact. And I'm sure the questions that she's asked, I'll channel those into the Q&A at the end. So thank you very much, Didzom, for that fantastic work.
Thank you.
So we've moved from the essential diagnostics for neglected tropical diseases in terms of the WHO's overarching guidelines, in terms of countries forming their national EDL programs, to a very, very detailed, robust look at access. And we wanted to come out of that somewhat and just have a look. Really, one of the things that COVID, we mentioned, we can't escape having to mention COVID, I'm afraid. It's, you know, the backdrop to our lives in many, many aspects. One of the things that COVID has really done, and I'm sure you all agree with me, everybody out there in the public is now a public health expert per se. They're very, very much, people are very aware of the kind of the effect, the impacts of social determinants of poverty in relation to disease. COVID has really shone a light on that. COVID has also shown what can be done when different, in terms of the vaccine development, what happens when intellectual property straitjackets are removed, when collaboration across different platforms, different, how to put it, disciplines is actually done. What happens? You reduce the time to market from 10 years to 1 year for several vaccines. A lot can be done in this spirit of collaboration that COVID has enforced upon us in many, many ways. And one of the kind of, how to put this, terms that people are now really talking about in an engaged manner is that of the impact of modeling. Modeling seems to be the one thing that a lot of people have gravitated towards. I'm very much more aware of modeling and the impact of that to the fight against disease. And it never truer than in the NTD setting. So we thought it would be a very good idea to have this disease focus, which we are doing on schistosomiasis for this particular session. But we'd start with Dr. Jessica Clark from the University of Glasgow, looking at reconciling egg and antigen-based estimates of Schistosoma mansoni clearance and reinfection, but from a modeling perspective. How can modeling inform these studies? So I think to start this session, I think a round of applause for Dr. Jessica Clark there, all the way from Glasgow. I think that's enough from me, and I'm going to back out. Jessica, I think you've got your slides there. Yep.
I do.
Over to you.
Are we here? Yes.
We can see you perfectly.
Great. Amazing. Well, hi everybody. Thanks for coming to listen to my talk, and also thanks for inviting me. Yeah, I'm based at the University of Glasgow, and today I'm just going to take you through some of the work that we've been doing to understand really the temporal dynamics of clearance and reinfection post-treatment when we're using both these egg and antigen-based diagnostics. And also, I know we have the chat, but if you'd like to get in touch later and ask any questions, you can find me on Twitter, or please feel free to send me an email. So just a brief overview of this quick talk, really. So I'll just lay out the question and why we think it's important. I think we all know, but it's always nice to lay it out. Give you an overview of some of the data that we're using to parameterize these models. I'll give you a brief description of actually the model framework that we've used so that you can hopefully have a better understanding of what we have exactly done. And then finally, the important bit, I'll show you some results. And before I start, I would just like to make some acknowledgements. So this work was done with Dr. Poppy Lamberton and Dr. Joaquin Prada from Glasgow and Surrey. And also a big thank you to all of our co-authors and obviously our funders. And so 240 million people are affected by schistosomiasis, which is prevalent mostly in tropical and subtropical regions. We can see this on this map here, where the dark orange indicates regions with high transmission, so across the African continent, in South America, so in like Brazil, and across China here. And it most commonly affects communities, obviously, without access to potable water and adequate sanitation. And control obviously largely focuses on mass drug administration with praziquantel to reduce disease, and also things like molluscicides, WASH programs, so increasing the access to water, sanitation and hygiene, and also health education. And though we know that a lot of these interventions have been really, really useful and really amazing, actually we're seeing that some locations still experience really high sustained transmission despite nearly 2 decades of mass drug administration. And for example, villages along the shores of Lake Victoria experience, again, really high schistosomiasis prevalence. And Mayugi, Uganda, just here, is where the Lamberton lab has worked since 2004, working largely in these 3 schools, Bugoto, Bwanda, and Musubi, and getting really amazing detailed data, following the same students from year to year, and following mass drug administration that started actually in 2003. But as we can see here, so this is 4 years of prevalence estimates. You've got prevalence on the x-axis here. And I've just picked out a few years from this longitudinal data from 2004 to 2018. So we've got 2004, 5, 13, 18 here. And what we can really see is that this prevalence really has not changed over these years. And so the real question is why? And is this an operational failure or a biological failure? And basically, we hypothesized that regardless of the many reasons for operational failures, it would be characterized by rapid reinfection, whereas biological failures are more characterized by this insufficient clearance, despite these observed treatments that we're doing. And by biological failures, we mean things like schistosome evolution of resistance to the treatment, but also poor absorption of the medication by those being treated, or a high proportion of juveniles in those infections who are actually resistant to the treatment. And for some of the operational failures, we mean things like treating the wrong people, so missing out certain demographic groups, treating at the wrong time, so maybe not treating frequently enough, and also obviously insufficient treatment coverage, so actually we're just not treating enough people. And so to understand this persistent transmission, we need to understand the temporal dynamics of clearance and reinfection. And so for the purpose of this talk, I'm going to focus just on data from Bugoto. And I'm going to talk about an analysis that we've done from with data from 4 time points. So data were collected pre-treatment, 3 weeks, 9 weeks, and 6 months post-treatment. And 210 school-age children provided samples for CAT and CCA. And we actually scored the CCA tests in 2 different ways. So first of all, with the manufacturer's guidelines, which from now on I'm going to call CCA+. As a lot of people are probably aware, this runs from negative to triple positive. I got this figure from, or this picture from this paper, so thank you. And then we also scored them with the G-score, which has been recently developed. And you can read more about that in this paper here. It was not developed by us. You can read about it here. But it was scored, it's basically is a scoring system from G1, which is negative, to G10, which is the highest positive score you can receive. This is a set of dummy cassettes that you compare your test to. And so that reduces, hopefully, the inter-reader variation, as well as increasing the resolution across all of these scores. So we've got 2 scoring methods here and cat-cats for each child. And these data were fit to a hidden Markov model. And the way that the hidden Markov model basically works is that we have this unobservable hidden state, which in this instance would be the infection status of each individual. So obviously we can't see somebody's true infection status, so that's our hidden variable here. And so you've got your infection status, you've got an observable process that generates your data, or gives rise to the observations. And because we fit this with a Bayesian framework, we have our data likelihood. And basically an individual can stay infected, or they can stay not infected, or they can switch between these classes, so obviously indicating clearance or reinfection. And it's these probabilities that we're interested in. And so to account for the CCA data, the framework is similar, but we just adjust the model slightly. And just as a brief description, we link the intensity of infection and the CCA test scores through a logistic function in this likelihood function, where the mean true cat-cats count, which is estimated by the model, is the real number of the logistic function. And basically what this just means is that the cat-cat score increases, and we make the assumption that as that cat-cat score increases, the CCA score will also increase. And that means that we don't actually have to make any assumptions about the interpretation of the CCA score, so the trace score, or the G2 and G3, which is the equivalent or believed to be the equivalent in the G-score system. Okay, so if we first look at prevalence pre-treatment, estimated by each of the 3 models, so there are 3 models here. One is parameterized with just cat-cats, one is parameterized with cat-cats and CCA+, and one is parameterized with cat-cats and G-score. And sorry, these peaks here are supposed to be filled with color, so you might not be able to see those so well, sorry. But this one here, this is your cat-cats. So this is the prevalence if you estimate this using just the cat-cats data here in green. And we can see that that's about 82%. But if we include the antigen data in here, the antigen test data here, we can see that both the CCA+ and the G-score data provide a higher estimate of prevalence, but they also perform comparably. And if we have a look at clearance and reinfection, so in this figure here, you have your estimates just from the cat-cats data. And your clearance is on the top, your reinfection is on the bottom, and down the side here, we've got total on the top row of both panels, and then you've got your time points. So you've got baseline to 3 weeks, 3 weeks to 9 weeks, and 9 weeks to 6 months. So these are the times between each of our time steps. And if we look at clearance, we can see that here, using just the cat-cats data, cat-cats would look like treatment was very successful. 93% of children over the 6-month period are clearing their infections, and only 35% of those children become reinfected within 6 months. But if we actually use the CCA+ data in here, we can actually see that 20% fewer children are estimated to clear their infection, suggesting treatment is actually less efficacious than the cat-cats egg counts would suggest. We can actually see here, so we've got 72% are clearing their infections in total, and 51% of those children are becoming reinfected. So you've got fewer children clearing and more children becoming reinfected within that 6-month period. And actually, if we use the G-score data as well, the estimates are quite similar. You've got only 65% of children who are clearing their infections, and 44% of those are becoming reinfected. So both the CCA scoring methods are estimating a lower clearance and a higher reinfection than we would estimate than we would obtain from just the cat-cats data alone. But one thing to note across all of these models is that most clearance does happen within 3 weeks of treatment. So this line here is 3 weeks, and of the total amount of clearance, we can see that most of this is happening within 3 weeks, and that most reinfection is actually detected by 9 weeks post-treatment. So of all the reinfection that's going to happen, most of it has already happened by 9 weeks post-treatment. So what does this look like as far as prevalence at each time point? So we can sample from the posterior distributions for infection prevalence over time. And this takes into account all of this clearance, all of this reinfection, and we can estimate prevalence at each time point. And you can see that your CAS-CATS is still in green. So we can see that this drop in prevalence at the 3-week mark, I think it puts it at around between 10 and 12%. But we can see that if we use the CCA plus and the G-score method for scoring the CCA tests, then we can see that actually prevalence, again, is around 20% higher and is consistently higher. And we get a very rapid bounce back in prevalence, so that by 6 months, we're really very close to the prevalence that we started at to begin with. And so to conclude, both the biological and operational failures are maintaining transmission, and this is indicated by this incomplete clearance and rapid reinfection. And obviously what this basically means is that the force of infection is not being reduced by this treatment. You can ignore the one in the middle, that was a mistake, that's not supposed to be there. And the next point to take home is that your frequent surveillance is essential. So 3 weeks post-treatment does capture the clearance dynamics, but it's too early for estimating reinfection, whilst 9 weeks post-treatment does capture the reinfection. And this really has implications for surveillance and monitoring programs. And so with that, I would just like to say thank you, and I look forward to any questions that anybody has during the discussion.
Thank you very, very much, Jessica, for that. Very interesting, because the modeling you're doing is kind of like giving a line out to potentially even behavior, issues on behavior of those people in terms of reinfection, their water contact behavior, urination, defecation. You mentioned Bugato. I had the pleasure and honor of being out in Bugato with Poppy Lamberton's group for the Schistosomiasis project. We run a developmental theatre behavioural insights.
Yes, yeah.
So we're very familiar with Bugato. Some very good memories from that place, and some questions already coming through. Some from the Glasgow group. Elias is already asking questions. We'll come to the Q&A following the next presentation.
Perfect.
I'd say thank you very, very much. A clear show on how your modelling can inform so much in terms of the fight against schisto. So thank you very, very much.
Thank you very much.
Thanks, Jessica. And that brings us to our next speaker. And I'd like to introduce, we've had the impact of modelling onto clearance, reinfection, and what it means to surveillance, disease surveillance. We thought we'd bring in the kind of a look at the different types of diagnostic markers and what they reveal when you're looking at monitoring treatment with these patients who are taking praziquantel for schistosomiasis. I'd like to bring in, welcome Dr. Pietje Hoekstra from the Leiden University Medical Center at the Netherlands. Pietje, hi there, good morning to you. Hello there. I'm going to hand over the floor to you. Thank you very, very much. And I'm just going to back out. Thanks a lot.
Yes, thank you. So just to confirm, can you see my slides?
Yep, perfectly. It's all clear. Thank you.
Okay, thank you so much. Thank you all for joining, and also thanks very much to ISNTD for inviting me and giving me this opportunity to present. So I'm Pietje Hoekstra. I'm a PhD student at the Leiden University Medical Center in the Netherlands. And today I'll be talking about our repeated praziquantel treatment trial in Côte d'Ivoire. And more specifically, I'll be talking about Schistosoma X, circulating antigens and DNA, and what do they reveal after treatment. So as Jessica also indicated in her presentation, schistosomiasis remains a major public health problem. We do have praziquantel treatment, and it's usually given in the form of preventive chemotherapy as part of mass drug administration campaigns. And in our trial, we specifically looked at praziquantel and its efficacy. So we were interested in cure rates. So in this little table, you can see an overview of the reported cure rates of praziquantel for Schistosoma mansoni. After one dose of praziquantel, it ranges between 42 and 79%, while for Schistosoma hematobium, it ranges between 37 and 93%. And if you increase the number of doses, so if you give 2 praziquantel treatments, the cure rate can be increased up to 99% in case of Schistosoma hematobium and 93% in case of Schistosoma mansoni. However, these cure rates are determined by using a classical microscopy, so urine filtration for hematobium or catocaths for Schistosoma mansoni. And we believe that these cure rates are overestimated if you use this classical microscopy. It's known that microscopy can lack sensitivity, especially in case of low intensity infections or post-treatment measuring. And this then leads to a higher number of false negatives, which then also automatically leads to a high cure rate, which is actually incorrect if you have these false negatives. So this is more or less the rationale for our REPS, our repeated schistosomiasis treatment trial, in which we wanted to determine the efficacy of repeated praziquantel treatments against Schistosoma mansoni. On the one hand, still using classical microscopy, so catocaths, but also on the other hand, using more sensitive antigen and DNA detection methods. And we performed a clinical trial, a randomized clinical trial in Côte d'Ivoire in school-age children. They were screened for Schistosoma mansoni infection based on catocaths and POC-CCA. And if they were positive in both tests, they were included in the trial. And they were randomly assigned to either the standard treatment group receiving only 1 praziquantel treatment or the intense treatment group receiving 4 praziquantel treatments at 2-week intervals. And in this little overview, you can see the design of the study. But if you want to know more details, then please have a look at the published study protocol, because I do not have time to go into all the details. We collected at several time points, we collected samples. All stool samples were subjected to catocaths in the field, and afterwards PCR analysis was done in Leiden. And for the urine samples, POC-CCA was performed in the field, and CAA analysis was done in Leiden. And I'll just jump to the results now. So when we look at the cure rate, first starting with the classical microscopy data, the catocaths, you can see that in both groups there is a major decrease in the total number of positives from after 1 treatment to less than 25% positive. And this number increases again if no further treatment is given. While if you give more praziquantel treatments, the total number of positives reduces further in the intense treatment group. And we calculated the cure rate based on the prevalence 4 weeks after treatment compared to the prevalence at baseline. And this resulted in a cure rate of 68% for the standard treatment group compared to 86% in the intense treatment group. Then if you add the POC-CCA data to that, we could see that this is quite different pattern. A lot of the children remained positive by POC-CCA over time. And also there was not a major or significant difference between 1 treatment or 4 praziquantel treatments, leading to a poor cure rate of 31% in the standard group and 36% in the intense treatment group. So when these data already have been published, and now I would like to add some preliminary data on CAA and the stool PCR. So first of all, the CAA data more or less confirmed the POC-CCA data. So also here, the majority of the children remained positive over time, even after 4 treatments, and actually no difference between the 2 groups was observed. And the cure rate was even lower than POC-CCA, 23% in the standard treatment group compared to 20% in the intense treatment group. And then looking at the stool PCR data, we actually could see a similar pattern to the catocaths data. So first a decrease in the number of positives, and then more or less an increase again if you do not treat, and a further decrease in number of positive if you give additional treatments, leading to a cure rate of 48% in the standard treatment group and 78% in the intense treatment group. So in addition to cure rate, we were also very, very interested in reduction rate. So looking at the intensity of infection to see whether we could also observe a difference between these 4 diagnostic methods. So here we are looking at the catocaths data. We can see that the mean EPG decreases after 1 treatment. it already decreases significantly, and then it further decreases if you add if you give additional treatments, and it's more or less steady and increases again if you then give no further treatments, leading to an intensity reduction rate of 83% in the standard treatment group compared to 95% in the intense treatment group. So then we added also the POC-CCA data, and here you can see the quantification of the POC-CCA data, that there is also a reduction in CCA levels in these children, and that there seems to be a difference between giving 1 or 4 treatments, leading to a reduction rate of 54% in the standard treatment group and 63% in the intense treatment group. Then if we look at CAA levels in urine, we also see here there's a steep decrease in CAA levels already after the first treatment in both groups. And actually, from this graph, it appears that even if you give additional treatments, CAA levels do not further decrease much more compared to those who did not receive additional treatments. Resulting in a similar reduction rate for both groups, 89% in the standard treatment group and 93% in the intense treatment group. And then lastly, the stool PCR data. Here again, a decrease after the first treatment and a further decrease if you give additional treatments. Leading to a reduction rate of 83% in the standard treatment group, and the intent was 99%. So just to give you a quick summary of these data, because it's quite a lot of data and quite a lot of conclusions you can draw from this. But basically, first we've shown that using traditional catechats, we observed a similar cure rate to what's been published previously, and also that we could improve the cure rate by additional treatments. However, if we use the more sensitive POC-CCA or CAA and PCR methods, we can actually confirm that the cure rates are overestimated, so that the cure rates are much lower compared to what you measure with microscopy. And then looking at the intensity of infection, we can see that in all 3 markers, so the Schistosoma X, antigens, as well as DNA, there is a rapid decrease to very low levels already after the first treatment. And then based on X, you can see a rapid reestablishment of infection after the first treatment. And also, there's a surprisingly small difference between 1 and 4 treatments if you look specifically at CCA and CAA. And then I think for all tests, we can see that even after 4 treatments, there is no full clearance of infection. So this here is a list of some potential reasons for this limited efficacy, and I think Jessica also discussed already a little bit about it. You could question, is the drug really taken? And I think in our trial, we did observe treatment, and the study physician as well as the nurses really made sure that the children took the treatment. So we had more than 95% compliance rate. So that should not be the case, but perhaps the juveniles that were not affected, they become adults. They can start producing eggs or excrete antigens. And there is also some other reasons listed here and also extensively discussed in our first paper on the catechats and POC-CCA results. So I won't go into detail here because of time. So conclusions from this study, in particular, if you look at egg detection methods, so that involves catechats and PCR, we can see that there's the cure rate increases if you repeat the treatment, and also you can see there's the difference between giving 1 or 4 treatments is really significant, and also there's a big impact on the intensity of infection. Then, if you look at worm detection methods, so another aspect of the cycle, looking at the POC-CCA and the CAA analysis, you can see we see that there is a poor cure rate in both groups, and actually there's no difference if you give 1 or 2 treatments. This does not seem to affect the cure rate. However, we did see a really good impact on the intensity of infection. So, and to conclude is that these findings really highlight the need for more research to reliable and more accurate diagnostic methods to really accurately determine the prevalence, and also to answer the question, is MDA really needed, or should we do something different, or should we do it at different time intervals, and also to accurately quantify the intensity of the infection. And lastly, also very important, you need accurate diagnostic tools to monitor and evaluate treatment efficacy. And with that, I would like to thank all of my colleagues at LUMC, but also at Swiss TPH, who contributed to the study, and our colleagues in Côte d'Ivoire who performed the study, and also the funders. And also, I'm happy to take any questions. Thank you.
Thank you very, very much, Pietra, for that. Some fantastic results there being put forward, and some huge implications, I'd say, in terms of this overestimation of cure rate to the mass drug administration, or the evolution of the mass drug administration programs that are out there, and especially topical because we are now moving into the age of pediatric praziquantel. And I'm sure this type of study is really going to inform the future rollout of those kind of studies, especially with this 4 treatments threshold that you've kind of uncovered. It really, to us, illustrated how diagnostics are going to really, they speak volumes to way outside of that kind of the immediate focus of the study. So something we're going to pick up on the Q&A. I've just been informed that we're going to extend this session to 5 to 11. So we have about 15 minutes to have some decent Q&A coming through. And so on that basis, I'll just stop your slide presentation. If I could ask the other, thank you very much for that, Pietra, brother, and just ask the other panelists, Didzom and Jessica, to come back on. Fantastic. We've had some great questions come through. I'm just going to access those questions and kind of put them to you. Kind of before I do that, I was going to ask something. We wanted to have access in this panel. This is why Didzom's there. I know it's visceral leishmaniasis in Kenya and schistosomiasis, a totally different disease setting. However, in line with the kind of central thrust of the last 2 days, bringing access into a more centralized position, what I wanted to ask is this question that, to Jessica and to Pietra, your work obviously is you're looking at the modeling on one side, and then the actual the clinical management of these patients in terms of their surveillance after treatment. With your approach there, using 2 different approaches, the outputs seem very, very complementary, and I'm just wondering how, given that the WHO's moving from a how to put it, action-based measure of impact to a far more an actual impact measure. So what does it mean to those communities affected by these diseases? How do you translate your work to kind of fit that shift? That's the kind of question I'm asking. Who do you need to speak to? Because you're really informing MDA programs on one side. You're also showing quite a range of impacts. How do you translate that from a modeling and from your perspective, Pietra? How do you translate that into a more impact measure? How do you do that? I'll ask Jessica first.
Who's going to jump in?
Yeah.
Well, I think you slightly begin to touch on it. So the modeling obviously does influence, or maybe have some influence on programs moving forward, treatment programs moving forward. But what comes out of that, to some extent, is data also. So we have these programs, people are collecting data as we go, and the model is only ever as good as the data that it's being given. And hopefully by moving away from sort of just measuring, 250 tablets were handed out or whatever it is, but actually measuring the impact of handing out that treatment, we end up with more data with a higher resolution that we can then use in the models, and especially more mechanistic models where you really need a value you're putting in a numerical value of how effective treatment is or any of these things, then that data becomes incredibly important. And hopefully my view of it would be by moving towards measuring that impact directly, we will end up with better data that will then re-inform the models, and we can see this kind of synergistic progression between the programs and the models, and then the programs and the models.
Almost iterative, almost an iteration.
Yeah, exactly. Yeah.
Fantastic. And thank you for that. Pieter, from your side, you're basically telling people you need 4 doses, and there's still going to be the disease is still there, the parasite is still there. The MDA programs in terms of the cure rate estimation. What's your message to those impact measures?
Yes, thanks. So I really think that this study, even though it's a small clinical study, it really shows that these cure rates, especially based on microscopy, that they're not as reliable as people used to think. But I do think that before making any recommendations, we should do a bigger scale trial and to implement it on a larger scale, and also to really look at reinfection, for example. That's probably one of the reasons why also the number of infections remained high over time, is that there was high transmission in the area. But we just looked at these 4 diagnostics, and we did not have any additional funding to look at additional aspects. So we would really like to do more research to look at these all these specific items.
Yeah, I'm just thinking of some of the behavioral insights that Didzom had kind of highlighted in the Kenya study. I totally get it's a different disease. However, do you think your modeling processes would move out of the biological modeling, out of the operational modeling, to include behavior? Because in one way, you are alluding to some kind of behavioral element that's allowing the schisto to persist, to the reinfection. Water contact behavior, what is it that you're pointing towards? And is there scope to involve that in the modeling?
Yeah, so I think that this is where there's a kind of a split, right? So the model that I presented today is more of a statistical approach to estimating this clearance and this reinfection. But we can also have mechanistic models, such as the ones that are used by the NTD Modeling Consortium, where they are, there are variables in there that control systematic non-adherence, and there are variables in there that allow for systematic non-access. Which is actually something that I'm working on at the moment with Professor Deirdre Hollingsworth, which is amazing and super interesting. Yeah. And so those mechanistic models are, they are the models, I think, that are more capable of taking in this behavioral element. And again, but the problem there being is that we need values for these. We need values for these parameters. And so understanding just how large these groups are that aren't able to access treatment, for example, is something. It's obviously very location dependent, but it's also a variable that to include it in the model, we need a value for it, and therefore data needs to be collected on it.
Yeah. Okay. So, I mean, I hope you're hearing that, Didzom. I'm sure FIND in its overarching position as the PDP, given the amazing kind of robust nature of your engagement with access, as you illustrated in your presentation, will probably have those data sets. Perhaps not perhaps in Schisto, but definitely per country. And perhaps you guys need to get together to talk about that. Coming to the questions from the audience, we're getting quite a lot, and I'm duty bound to ask those as well. Some of these might be a bit specific to the presentation, so I'll start with Didzom, if that's okay. Delna Gandhi, ex-DFID, I'm sure a lot of you on this audience will know Delna personally. She commented, wonderful presentation to Didzom. Great to see the impact. 60% negative doesn't seem to be too high. What would you expect it to be? She's saying she used to work in West Pokot in Kenya and recalls the VL burden. So the question is that 60% doesn't seem to be too high, given her experience. What would you expect it to be?
We clearly would like to see this reduced further to 40-30%. Our main focus here is to make sure that the diagnostics algorithm is strictly followed. And because VL is co-endemic with so many other diseases, there's malaria in the mix, sometimes there's West Nile virus, there are all these febrile illnesses. There is that need to have a strong clinical suspicion before you test. But we've realized that as Dr. Mussi said, there seems to be over-testing in some of these areas. Laboratory technicians and the clinicians, they prescribe RDT for VL directly without making sure that the steps are followed. So that's one thing we like to see done first. And also, it's not just because there is this proportion that we would like to reduce, but it has to do with the cost of the test and the accessibility of the test, which is a challenge. It takes a long time. COVID has shown us last year that it's not easy to get the test in the country. You need a long lead time to request for the test for WHO to make them available. So if it is being used on patients who do not need them, then at the end get shortfalls when there are actually cases that require to be treated. So these are some of the challenges.
There certainly are challenges. Helena Uliata from the Ministry of Health Indonesia is asking, what happened to the 60% negative result?
What happened to the... So technically, per the diagnostic algorithm, if there is a strong suspicion and RDT is negative, then DAT is supposed to be done. But this is not always done, which is another of the challenges we're trying to address. We have to constantly keep reminding the health professional, the personnel, to follow the algorithm as best as possible.
This knowledge gap is very interesting, because whose responsibility is it to inform who can we make partnerships with to bridge the knowledge gap at HCP level? I think that's a very interesting kind of avenue that's opened up there. We're getting some schisto-specific questions as well. Dr. Maria João Govia from the National Institute of Health in Portugal is saying, very interesting work. Do you think that this approach will be suitable for Schistosoma hematobium or individuals with co-infections with these two parasites? I suppose I'll ask Pietra first, and then I'll go to Jessica, if that's okay.
Yeah, so in our study, indeed, we focused on Schistosoma mansoni, so we could do a similar approach for hematobium, especially the CAA, the more sensitive diagnostic. It can measure all species, so that's no problem. The POC-CCA, the point of care test, we know it's more specific for Schistosoma mansoni, so that would not work necessarily for hematobium. So then the set of diagnostic methods would be different, but I think definitely it would be possible to look. And also, I think co-infection would also be really interesting to have a look at. And in our study, we really specifically focused on mansoni, and we excluded hematobium cases. So
fantastic, thank you for that answer, Petra. Co-infections certainly are of interest, and I was going to ask something about that with HIV and VL to DIDS on, perhaps as a solution to this knowledge gap issue. But there's a question come through for Dr. Clark, for Jessica, from Adriana Erica Miele. Thanks, Dr. Clark. Are you planning to do the same surveillance in places with lower prevalence? Good question.
Yes. This is maybe a question more actually for Dr. Poppy Lamberton, because it's her group. But it has definitely been something that we've discussed, is actually increasing the number of diagnostics. So obviously with this type of analysis that we've used here, it only gets more accurate, essentially. You can add in more diagnostics as long as you kind of mathematically account for the link between them. And so, yes, kind of validating it at a lower intense or a lower prevalence is, I think, vital, actually. And then also potentially using more diagnostics. And that actually kind of links to the hematobium question as well, because the prevalence is often lower. And so we would have to validate it on a lower prevalence scenario, basically. But my assumption would be that it would be applicable to hematobium.
And there's a question from Elias from the Glasgow group. Thanks, Jess. Would you recommend the change? Would you recommend to change from the 0 to 3 or CCA plus score to the G score? Does it really make a difference?
That's a good question. So we are working on validating a similar model at the moment that is basically providing an estimate of a probability of infection for each G-score and for each CCA plus score. And roughly what we are seeing is that, and this is very preliminary, we're still validating this, but something around an 80% probability of infection if you have a trace score, whereas with the G-score 2, that's something more like a 20% infection or a 20% probability of infection, versus a G3 is somewhere between 70 and 80% probability of infection. So it definitely does increase the resolution across the different scores by breaking it down. One thing that we are potentially also noticing though is that once your cat count is high enough, you've kind of saturated the scores, and a positive is a positive, and the higher the G score goes, it doesn't really tell you any more about the intensity of infection that we're looking at. And so that's, I mean, this is work that we're working on validating at the moment. It is really interesting and really exciting, because I think that's kind of an answer that a lot of people have wanted, but we're not ready to share it entirely just yet.
What I would say is I think the amount of questions that we're getting in from the GHIT Fund, from Isaac Chinua at the GHIT Fund, Professor Bonnie Webster, all sorts of people coming through with lots of questions on the Schisto side. You might consider having an ISNTD Connect session later on to have a real opening of that and answering those questions. I'd like to end with a VL question, because at times of the essence, I've got about 4 minutes before they kick me off and I get in a lot of trouble. So there's a question from Ikram Guziani. It's for Didziom. He's asking, there are ongoing improvements on VL diagnostics. How has this taken into account? Has this been taken into account into the system in place in Kenya or in other countries?
So we're currently exploring new studies to look at the new diagnostics that are there. There are studies going on to compare the current tools, ARCHI-39, together with data and microscopy, as well as ARCHI-28. So those results are currently in clinical evaluations. We hope those will be available within this year.
Fantastic. So you are taking them into consideration and you are adapting in accordance to that. I do think we should have a follow-on ISNTD Connect session, just because I really feel bad when we can't answer the questions that people have kindly put in. I'm sure you're seeing those come up on your chat boxes as well. There's some dialogue started with Poppy, who's on the group as well, answering some of those questions. And people are already, so Sri Lanka, Miluka, yes, please do have a separate Connect session. So there's definitely appetite for that. I think we'll come to that. I'm sure we'll be in touch about that. But I'd just like to say thank you very, very much to Jessica Clark, to Didzom D'Souza, to Pietra Hoekstra for a wonderful session. It's been a very interesting morning, and I'm just going to have to leave this room and ask everybody to go on to the second link for the new room, the next session, which is going to be starting in literally a few minutes, which is going to be looking at diagnostics innovations in terms of the various tech innovations that are out there, perhaps driving us all towards a better future for NTDs. So on that note, thank you very, very much. Great discussion. People are, thank you all very much. Some great comments coming through. Thank you so much. Have a wonderful day, and we'll be in touch with the Connect, the series moving forward. Thanks a lot, guys. All right.
Thank you. Thank you.
Bye-bye.
Bye-bye.
Yeah.